a reminder, just look directly into your cameras when you are speaking.
Good afternoon, everybody. This is Ellen McKenzie. We are just sitting here waiting for folks to sign in, so we'll just give it a couple more minutes. They're rolling in. Okay, I think we're just about at 200 people. I know there are still, the ticker is still going, so I'm sure more will join us. But I would like to get started and welcome everybody. And thank you for joining us for this wonderful event. I hope your summer is off to a good start. I know some of you are already teaching in summer institutes, and some of you are starting to teach in the summer term. Others of you have a little bit of a reprieve before we start up again in fall, but I do want to take this opportunity again to thank everybody for everything they're doing. I just got off a call with President Daniels and Provost Kumar, who've met with a few of our younger faculty because they want to better understand the particular challenges our young faculty are having in doing everything they have to do as young faculty, as well as dealing with the pandemic and everything it brings. So I do want to take the opportunity to thank you for all you do. And if there's anything I can do for you, let me know. But we're here today for a wonderful celebration of a wonderful person. And that is the promotion, although it happened a couple of years ago, but the promotion of Janice Bowie to professor. Becoming professor, being appointed a professor at the school represents an incredible achievement and confirms not only the respect and high regard of the school, but also of colleagues across the country and across the world. This Dean's Lecture was designed to introduce the Hopkins community to the work of newly appointed or promoted professors and to provide a forum really to promote cross-departmental and awareness and collaboration. And as I mentioned, today's speaker is one of our faculty who make this school so very special, and that is Dr. Janice Bowie. To say that Dr. Bowie is an expert in health disparities and community-based research methods just begins to tell the story. Prior to coming to Johns Hopkins, Janice spent over 15 years at Virginia's Department of Health, where she held several positions, including Director of the Division of Chronic Diseases. During her tenure, she oversaw a statewide cardiovascular risk reduction program supported by a block grant from the Department of Health and Human Services. She also led the establishment of Virginia's Office of Minority Health. She is among a small number of faculty who began their career in the practice of public health before transitioning to an academic setting. This early exposure and experience shaped her understanding of the needs and challenges of practitioners who are charged with translating the research that we all do into practices and policies that really make a difference, as well as advocating for resources to support the implementation of these policies, services, and programs. Her research examines approaches that lead to the success and sustainability of community-based interventions. She also studies the implication of religion and spirituality for prevention and treatment. Now Janice came to the Bloomberg School as an assistant professor in the Department of Health Policy and Management back in 1997, and then transitioned to the newly created Department of Health Behavior and Society in 2005. She was promoted to rank of full professor in 2017. So you can see we're still a little bit behind in recognizing our newly promoted professors. We're still playing some catch up. So Janice has been in her position as an esteemed professor for a couple of years. She is core faculty in the Hopkins Center for Health Disparities Solutions and co-investigator in the Center to Reduce Cancer Disparities at the Johns Hopkins Sidney Kimmel Cancer Center. She serves on the advisory committee for the Jackson Heart Study Graduate Training and Education Center at the University of Mississippi. She is board chair of the Community Law Center in Baltimore and is a member of the National Heart, Lung, Blood Institute's Sickle Cell Disease Implementation Consortium. For 12 years, from 2000 to 2012, Janice also directed or co-directed the Kellogg Community Health Scholars postdoctoral program. Most recently, she was appointed, and I am particularly pleased that she accepted our offer to become the school's director of our Doctor of Public Health program in 2019. And even more recently, she was named a Bloomberg Centennial Professor in recognition of her role as DrPH director and all that she brings to that position. And I can say in the short time that she's been DrPH director, she has just built that program up, and we're just so thrilled to have her in that position. She's also been a beloved faculty advisor to many doctoral and master's students and has been recognized by the department as well as the student assembly with several special teaching and mentorship awards. Dr. Bowie received her Bachelor of Science in Health Education from Shaw University and her MPH from the University of North Carolina in Chapel Hill. She received her PhD in 1997 from our own Department of Health Policy and Management. Janice was honored with a Harriet Hilton Barr Distinguished Alumni Award from the School of Public Health at the University of North Carolina, Chapel Hill, and the Thomas Bruce Award for Community-Based Participatory Research from the American Public Health Association's Community Caucus. Today, Dr. Bowie will be speaking to us from our multimedia studio in the Bloomberg School. And I'm assured that under very strict social distancing guidelines, of course, she is joined by Jeannie Hahn, who is a research project coordinator for Consumers United for Evidence-Based Healthcare and Cochrane Eyes and Vision USA satellite. And Ms. Hahn will facilitate the Q&A session that will follow Janice's talk. So I can't be more pleased and delighted to welcome Professor Janice Bowie. I'll turn it over to you, Janice.
Thank you, Ellen, for that warm introduction and also for giving me this platform this afternoon. I'm going to share my screen now. Good afternoon, everyone, and welcome to my Dean's Lecture entitled Community-Centered Public Health, Research and Practice, Tenets, Challenges, Benefits. I'd like to dedicate my presentation this afternoon to Toby Citron and Elijah Cummings, both who were recently elevated and both who were vanguards for community-based public health and have influenced my work. I'd like to have you spend this time this afternoon with me on this journey, or as I could have tagged it, the road less traveled. I'll talk about the start of my life, and then I'll share some of the early days of public health, my educational pursuits, my time here in the academy at Johns Hopkins in the Bloomberg School of Public Health, and then finally my vision for the future in terms of tenets, challenges, and benefits. In these early years, my interests and beliefs were shaped in having grown up in de facto segregation. At this time, separate but equal laws allowed African Americans and white Americans to be educated separately, and Jim Crow laws enforced racial segregation. During my time growing up in Richmond, Virginia, I operated in exclusively segregated spaces. My walk to school, my walk home from school past the Rosa D. Bowser Library, as well as my involvement in Black churches. And the Black churches I attended were also segregated, but it's also where social justice and community-centered orientation happened, and where religion, for me, went from the sanctuary to the streets. I also grew up around these monuments. Richmond is known as the Confederate capital of the South. But Black Richmonders did not and do not revere these statues. We understood that they did not reflect our history. Rather, they reflected hagiography. They were put there in a very flattering light and for the purposes of promoting a political agenda. As part of the early years, it helped to really shape my identity as a Black woman. And no matter where I am, it allows me to have a connection to community because I embody these experiences. And therefore, I'm never separated from my early upbringing and the effects of my de facto segregation. So my early beginnings in public health started when I was 13 years of age, and I spent my summer as a volunteer with the Richmond City Health Department in the Bureau of Public Health Nursing. I remember these public health nurses well. They had a consciousness about the whole community. And the Black nurses in particular understood the neighbors and the neighborhoods. Some of them even lived in the neighborhoods of the patients and families where they made home visits. They understood who the community leaders were. They knew how to access the essential services that these patients and families needed. And what I saw was how they were able to mobilize the community. So even before my upbringing around, before I understood the principles and practices of public health, and even before I understood what community engagement meant, or before we had a name for it, I was exposed to this experience. I worked in the same health department in Richmond after my completion of my undergraduate education. And now I'd like to shift to just provide a little time, spend a little time on some of my theoretical and research grounding. So my MPH and PhD degrees gave me another level of substance, another perspective, and another understanding of how important was this work. And during my time at UNC Chapel Hill, I was exposed to community change agents and scholars, among them Doctors John Hatch and Jack Geiger. They were early collaborators and public health leaders in the formation of neighborhood health centers in the Mississippi Delta and in Boston, Massachusetts. And they taught me about the integration of the voice of impacted communities. My mentor, Dr. Hatch, and others at UNC provided me with a compass for understanding behavior, but within the context of the social influences of health and community. I then returned to practice what I had learned and experienced at UNC and was chosen to direct the Division of Chronic Disease Control. As I honed my administrative and leadership skills in this position, it was really during my travel across the Commonwealth where I saw the stark disparities in health. I saw pain and sorrow, and I saw compromised quality of life and the unevenness, in particular in healthcare delivery. It was then that I realized while my MPH degree allowed me to be at the table with decision makers, I needed another degree to further and more critically enhance my understanding and also how to advance this work and to bring analytic skills and rigor. When I came to the School of Public Health here in East Baltimore, working collaboratively with community was already a core foundation of public health. In my trajectory, though, I chose to build upon this body of work that had been started with, and to build on the pillars of those who were doing this work, a small number of faculty in the School of Public Health: Lee Bone, Bob Lawrence, David Levine, Carl Taylor, and a few others who were both involved in this work on the domestic as well as international front. All of these giants helped me to appreciate the rich contextual perspective and the relevance that was needed in community-centered research. It's where CBPR, or community-based participatory research, converges at both the intersection of practice and research. Then, following my education, I began my work here in the academy. But as we know, these social influencers of health are the conditions in which people live, work, grow, and age. And we know that they include working conditions, employment, access to essential goods and services, and the like. And it's these conditions that reflect the inequities that are experienced by many communities that have been ravaged by disadvantage and that lead to poor health and health outcomes. But what I would like to elevate is that we know the power of partnerships to help us solve our most pressing public health challenges. And this was recently echoed by the Surgeon General. And at the core of these partnerships are community-based organizations and groups who know their people and communities best and who are committed to working collaboratively to reduce health inequities and to make their communities healthy and safe. Historically, interventions and actions to promote health were driven largely by professionals with little or no input from the intended beneficiaries. But in recent years, the movement from practitioners, policymakers, and researchers has been to engage members of the community in public health interventions. Broadly defined, community engagement involves the community in the identification, the design, the delivery of the intervention, and it engages with individuals not as intervention participants, but in the actual work of designing, implementing, and delivery. Community engagement has been advocated largely as a strategy to reduce health inequalities. And these health inequalities, as we all know, are most evident among groups that have been marginalized and that have poor health than many others in our society. We clearly also know, just as shown in the previous slide, that these health inequities are differences in factors that are modifiable. Again, thinking about housing and employment and education. And these are different from those fixed determinants such as age, genetics, and sex. This diagram, which I have often used in my work in community-based participatory research, certainly in my early years of working on cancer control within the faith-based community. But this depiction shows the many ways in which stakeholders can be involved in designing, identifying research and interventions, thinking about what the design should look like, participating even in the development of the proposals. I've had experiences in having stakeholder representatives actually help with thinking about the recruitment and retention strategies, where to recruit, how to maintain participants in the studies. along with also what are the best measurement instruments to be used to make sure that we were capturing the most important data and that was most relevant to them. And then also working on the analysis and in particular interpretation of findings, dissemination and translation. So what does the evidence around community engagement say? A few summaries and reviews have appeared in the literature, by and large supporting the effectiveness of community engagement. This particular meta-analysis was aimed primarily to answer the question, do public health interventions that engage community members improve health-related outcomes? A secondary question was, does the type of community engagement matter? And so this particular analysis included OECD countries. And this stands for Organizations for Economic Cooperation and Development. These are countries, 36 member countries that span the globe from North and South America to Europe and Asia Pacific. And these countries collaborate on policies to improve and foster prosperity, equality, opportunity, and well-being for all. And a total of 31 studies met the criteria for inclusion, and the pooled effect size across the interventions was positive. And what it suggests is that these interventions that engage communities can have a positive effect. It also pointed to that it didn't matter, at least from this particular analysis, if one approach or model of community engagement was better than another. So there are many forms of community engagement, but while there is, my work and my teaching has mostly resided within community-based participatory research, or as we refer to it commonly as CBPR. And this for me has been the focus of my work because it espouses collaborative practices and values. The emergence of CBPR was driven somewhat by the slowness in the gap between the knowledge produced through conventional research and the translation of this research into interventions and policies. CBPR has been defined as a critical approach to improving health and health equity. It creates a bridge between scientists and communities through the use of shared knowledge and experiences. It should lead to developing culturally appropriate instruments, thus making projects more efficient and more effective. CBPR should establish a mutual trust that enhances both the quantity and the quality of the data that is collected, and the ultimate benefit to emerge from the collaboration is a deeper understanding of the community's unique circumstances and a more accurate framework for testing and adapting best and next practices to address the community's identified needs, particularly again in ethnic and racial minority and underserved populations. So what does the effectiveness of community-based participatory research look like? I pointed out what the effectiveness and the evidence said about community engagement. But in terms of CBPR, one of the sentinel studies that was provided was this summary of the evidence that was commissioned by the Association on Healthcare Research and Quality. It included in this review only peer-reviewed studies. 55 of the studies were retained that met the definition of CBPR, and 60 met the criteria for intervention studies and outcomes. And what was noted were that there were 3 key factors that were identified as barriers to the effectiveness and the uptake of CBPR. They included whether that there were insufficient incentives for communities to serve as partners. Did they have the adequate training? Was there interest? Did they feel like that they would be valued and treated equally? Similarly, There were insufficient incentives for academicians to serve in this role. It takes a long time to do this work. Were there resources? Was there support from the institutions? And importantly, had these academicians been trained to work and partner with communities? And then finally, were there funding mechanisms? In the early days, they were few and insufficient. But what this review found was that there was very little evidence that increasing community involvement was in any way associated with low research quality. And this review has gone on to provide guidance for the evaluation of CBPR proposals, and really was the lead study, if you will, in the early days. And still to this day, this evidence is used and respected. Finally, a key challenge for evaluating the impact of CBPR is identifying what mechanisms and pathways are critical for health equity outcomes. The authors here first provided psychometric evidence of measures related to the model using confirmatory factor analysis. Further testing of the model and its impact was then conducted on participatory health research. In this study, the authors sought to provide an empirical test of the CBPR conceptual model to specifically understand what were the mechanisms for impact on research results, community conditions, and health equity. To test the model, they used a mixed methods design and conducted structural equation modeling to determine that in fact, the model was found to be suited and to be able to be used as a theoretical and evaluation tool for health improvement. The structural equation modeling then concluded that the context or the cultural nuances and historical collaborations provided the backdrop for partnership dynamics and relationships. If the partnering practices were indeed effective, then this would shape the intervention and research design. In other words, it would show the ability for partners to work together. Then if the intervention produced intermediate, which were capacity building and sustainability outcomes, and then distal outcomes, which were community improvement. So this model was indeed found, as I said before, to be suitable as a theoretical backdrop for community-based participatory research. And while the evidence base was being built for CBPR, it was also paramount to train scholars in community engaged research and practice to address the gap in academia, to develop effective partnership models and stimulate growth of community academic partnerships. At the time, our former dean of the School of Public Health, Al Sommer, entered in discussions with the W.K. Kellogg Foundation. And through a competitive application led by a former colleague, Dr. Bob Lawrence, and still our current colleague, Professor Lee Bone, that the Johns Hopkins, along with the University of Michigan at Ann Arbor and the University of North Carolina at Chapel Hill, became sites for training training postdoctoral fellows in CBPR. Over the course of 10 years, we trained 10 cohorts and graduated 46 postdoctoral fellows in areas and competencies so that they would be able to work in communities and engage in CBPR. 4 of those fellows are still here in our school. Shannon Frateroli in Health Policy and Management, Chris Haney in Environmental Health and Engineering, Terry Williams-Powell in Population and Family and Reproductive Health, and Suzanne Grieb, who is in the School of Medicine with a joint appointment in Health, Behavior, and Society. All of these these faculty members and colleagues are incorporating in their own unique way community inputs into their research process. And they're all thriving, I would say, here in this academic environment. So at the end of the 10-year period, we published a special edition within the Progress in Community Health Journal, Community Health Partnerships Journal, and I co-edited this issue along with my colleague, Jeannie Ng at UNC and Rich Lichtenstein at University of Michigan in Ann Arbor. So I'd like now to talk about how my work has been done, and just to give you a bit of a snippet of some of my community-based participatory work, as well as the partnerships and connections that I have deemed effective. And some of my work in the earlier years in faith, in the faith community, was really around cancer control, and in particular, breast cancer. So I have been fortunate to kind of cover a variety of different content areas in these faith partnerships, from work with my former postdoc, doctoral fellow, Dr. Danetta Hendricks Sloan, looking at the role of advanced care planning and end-of-life care within the Black church. Also, along with my colleague in health, behavior, and society, Peg Insminger, from her work with the Woodlawn study, longitudinal study in the South Side of Chicago, examining the use of alcohol and its effects with respect to religiosity, social resources, and mental health. Another paper and collaboration that I still am involved in to this day is with colleagues at the University of Maryland in College Park, Cheryl Holt, where we have been involved in community-based cancer control interventions, trying to look at what are those organizational factors that lead to increased capacity as well as sustainability of these interventions. And then finally, in my work with the Center for Health Disparity Solutions and my colleagues there, looking at the role of religious coping among men in their making prostate cancer treatment decision-making. We know that community-based public health also has implications for healthcare settings. And I have been fortunate for the last 4 years to engage in the Pediatric Integrated Care Collaborative with my colleague, Dr. Larry Wisso. Larry is now at the University of Washington in Seattle. And so we still together are co-PIs on this work that has been funded by SAMHSA with support from the National Child Traumatic Stress Network. And the focus of this work is to use the collaborative approach, which draws its strength from the creation and empowerment of multidisciplinary and trans-organizational teams. The Learning Collaborative creates an opportunity for teams to form, use protected time to plan, and to network with other teams. And we have conducted these learning collaboratives each over the course of 10 to 12 months, where about a team of 5 to 7 members come from their clinical organizations for 2 to 3 times a day, and of course, 2.5 day meetings, as well as phone conferences and webinars in between, and also using a Basecamp platform as a collaborative site. And so we have formed these learning collaboratives because, as I coin it, it's an opportunity for us to try and put the heads back on the bodies of children. We have done very well in this country in terms of meeting the physical needs of children, but the mental health needs of children and their families have often not had the same attention. I do think that now with so much stress and trauma that we are certainly seeing some reshaping of this. We also understand that these mental health needs of children and families are undergirded by many of those same social drivers that I showed in the social influences of health slide a while back. We use a collaborative change framework, and the purpose of the framework is to give teams and allow them to identify the priorities in each of these areas and to be able to choose and adapt strategies that help them to address the priorities that they're seeing within their respective communities and clinics, and then also to work with them to develop ways to measure their progress. In addition to the SAMHSA-funded PICC, we also have been funded by the Indian Health Service to try and improve primary care's capacity to provide whole family care. And we have collaborated with the Center for American Indian Health here at Johns Hopkins. And this work has been directed towards our tribal communities that are exposed to similarly to trauma and chronic stress. Over the course of these two combined PICCs, we have trained 77 teams thus far and close to 300 participants. And we certainly have represented a range of tribal nations and many communities from across the country. So the last of my partnerships has really been now in this work of CUE, which is Consumers United for Evidence-Based Healthcare. And this is a national coalition of 45 consumer advocacy organizations that was formed in 2003 by our former colleague, Dr. Kay Dickinson, who was a professor in epidemiology. And I began working with Kay prior to her transitioning to retirement. And we have been able to receive funding again from ARC and also from Patient-Centered Outcomes Research Institute to now elevate the focus of health equity in our consumer education and advocacy work. We provide web-based, evidence-based healthcare training for consumers to serve on Cochrane collaboratives, reviews, guideline panels, and studies. We also provide training for providers so that they will know how to work with consumers and patients that serve on these panels. A distinctive feature of CUE is that in order to maximize the evidence-based healthcare and literature and evidence, it is important that these organizations not be dominated by commercial interests so that they will not have to succumb to the industry's biases. So I've talked a good bit already about my early days in public health, my days growing up in Richmond, my time here in the academy, which just was a snippet of the years that I have spent here. And now I want to shift to a bit about the vision for the future. But just before I go there, I would like to share with you the top 10 reasons if you're thinking about CBPR, and now that I have tried to convince you of the evidence supporting both community engagement and CBPR. But just in case you're not sure, if you remember David Letterman, he was the host of the late night show for you very young people who may be viewing. He succeeded Johnny Carson. I won't go back that far. But this list starts with number 10. You only put CBPR in the proposal because that's what the RFA said. You already have enough headaches from your IRB, your dean, your chair, the promotions committee, and your spouse and partner without adding community members to the list of people telling you what you're doing. At number 8, you believe that as PI, you alone are ultimately responsible for the success of your study. You cannot cede control to community members who want to say in everything. Number 7, you get embarrassed easily. Number 6, it's not your fault that your university opened a $500 million state-of-the-art research campus while the community meeting is in an asbestos-lined basement of a building condemned by the city last year. You suspect your community partners won't understand the nuances of research, particularly the quantitative aspects, and certainly won't be interested in publications. At number 4, community members want you to talk to ministers, school principals, and block clubs, and daycare providers, and you don't have time for one more meeting. Number 3, you love the elegance of a well-designed study, presented crisply with precise data and superb graphs, but your partners just want to know what people think and feel. You want everyone to like you. At number 1, you don't actually plan to keep working with them after the grant ends. So I think the sentiment of taking the role of community-based public health seriously is reflected in this quote by a community member. I take the phrase public health very seriously, and I really think it's on us non-medical folks, in other words, the public in public health, who can really lead the charge in shaping the lives of not just ourselves, but also the generations that come after us. So for these last few minutes, I would like to reflect on a vision of the future, the tenets, the challenges, and to end on a high note with some benefits. So if you're committed to this work, it will take time and adequate resources for both you as a faculty member as well as your community. You have to be willing to listen, to learn, and co-design, and to engage in bi-directional learning and leading. You have to be willing to communicate many, many times over in many ways, to teach and also to learn, to set limits on what community partners can expect from you, as well as what you can expect from them. You have to have a desire to build linkages and coalitions and to step outside of our traditional partners to those that will help us to really begin to address the social influences of health that undergird these health problems. Will require patience, of course, a sense of humor and humility and passion. So in this moment, we are facing some challenges. In fact, we are witnessing 2 human-made crises, a pandemic that has laid bare the cruel inequities that pervade American life. And these 2 crises have convulsed our nation. A pandemic of COVID-19 that has pulled back the curtain, and a pandemic of racism that is pulling down the curtain. For those of us in public health, racism directly contradicts the values that we espouse to promote equity and well-being. I've said multiple times, the social influences can no longer be ignored. And lastly, we know that the delivery of medical care is changing, and the systems of medical care are also changing as they continue to struggle with the unrelenting chronic conditions and increased costs. Value-based healthcare is going to require clinicians to focus on preventive healthcare and outcomes, and will need consumers of health to think about how to address these solutions. When we think about community engagement, there are also some practical challenges that we must consider. We will need to evaluate and think about a broader community strategy. How are we going to train the practitioner of the future? What kinds of training will they need? And how will we finally conduct our research? How will we democratize the research process and work alongside of communities, rather than treating them solely as objects of our study? Martin Luther King Jr. said, when millions of people have been cheated for centuries, restitution is a costly process. Inferior education, poor housing, unemployment, inadequate health care, each is a bitter component of the oppression that has been our heritage. Each will require billions of dollars to correct. Justice, so long deferred, has accumulated interest, and its cost for this society will be substantial in financial as well as human terms. This fact has not been fully appreciated. This quote squarely reflects where we are today, years after this was first spoken by Martin Luther King Jr. But I'd like to end on what I have seen as benefits of this work in community-based participatory research and in community engagement. The advances in both forms of research and practice have been well documented, is rigorous, and theoretically sound. We are certainly seeing an uptake of these methods in biomedical science, biomedical and social and behavioral science research. And for those of us as scientists, we are certainly seeing an increase in our centers that embody, endorse, and integrate these approaches in research and recognize the importance of the community voice and consumers as equal partners. This is certainly true of the centers in which I am a member of, the Center for Health Disparity Solutions, where we have a community engaged and dissemination core that I direct. In our RICMAR, which is our resource center for minority aging research on Alzheimer's disease, within our Center for Health Equity as well. Also, we have seen this integration of CBPR and community engagement research in faculty promotion and tenure, as well as we understand that for us scientists, that in doing this work, that we can enhance both the internal and external validity of our research findings. And for our school here at Hopkins, I was given the opportunity to direct the school-wide DrPH program, as Dean McKenzie mentioned in her opening comments. And it has been an amazing opportunity to be able to further this work for mentoring and advancing the combined importance and the richness of the research and the practice and the policy and leadership that we do, as well as that these DrPH students in their own respective right and in their organizations are doing. I think as I reflect on the next generation and what kinds of characteristics we will need for people to be able to do this work in public health, it is going to be, and also as I think about what is it that I want to pass on to the next generation, I think we will have to be sensitive to the diversity of our country. I think that we will also have to think about our students and encourage them to be multilingual. I think the practitioner of the future is going to essentially is going to need multilingual skills or to be able to gain other language skills. We also have an aging population. And so we will need to be able to train and have the capacity in our school to train our students how to work with older populations. And this is an area that I believe is ripe for community engaged research, and that CBPR and community engagement can be responsive to these changing demographics. And so I want to just say how appreciative I am here at the end of this talk to my colleagues, both in the Department of Health, Behavior, and Society, across the school and across the institution, and even outside of the institution and in a number of organizations. I appreciate the opportunities that they have given me and the space and the support to be able to do the work that I have been passionate about. I also want to thank my students who I have been privileged to instruct, to advise, and mentor, and who have always shown me so much more and enhanced my horizons as a member of this esteemed faculty and also as a member of this research community. My community partners have been extremely gracious with their time and also sharing their lived experiences and pointing me to those things that are most important and that really matter at the end of the day. And then finally, I want to thank my family and friends. They have always been in my corner. They are my cheering squad. They have poured so much into me, and they have always been so supportive. And I'm immensely grateful for all of these. Thank you.
Thank you so much, Janice, for that wonderful presentation. So what we are going to do now is transition to our question and answer session. We have several questions that are lined up for you, Dr. Bowie. I'll start with a large picture question. So as an international leader in advancing CBPR and CE, what helped you to persevere over the many years you have engaged in this work, especially in light of the challenges you so aptly stated?
Wow, that's a really huge question, and I'll try to answer it in the most efficient way. I think the most important thing that I can say is that I have never done my work alone. There have been many people, many voices, and colleagues and community partners that have really been on the path with me to show me how to do this work. I also believe that if you have passion and if you believe in the value of the voice of people who are impacted by the work that we attempt to do, I think you find the stamina and you don't get weary in trying to do well. This work also, I have to say, doesn't happen in a linear way. Real health happens in real time, and real issues happen in real time, just as we have seen the disruptions that are occurring due to both COVID-19 as well as the mass violence that is taking place and the brutal killings of brown and Black people. So I say that to say that you have to be flexible and open and willing to take a step back and reflect on what is most important, and to engage with others to help you to bring this work along the way. It never ends, and just as the top 10 list that I shared from my colleague Stephen Rothschild at Rush is that you can't expect, just as when the grant ends, to then be able to re-engage communities. You have to build these relationships for the long haul. So I hope that helps help you at least think about if this is something that you are very much wanting to do, to understand it takes time and you will need the help of many, many people along the way.
Great, thank you for that. Our next question is, so Keeve is wondering if you could comment on ways we can better elevate our community partners and their contributions in the recognition we may receive as academicians for our collective work.
So thank you for that question, Keeve. I have to also say that Keeve is my homeboy. He grew up in Richmond, and my mother actually worked in Keeve's father's business back in the 50s and 60s. So Keeve, I would say that, that you first and foremost have to ask your partners, how would they like to be involved? And across that community engagement spectrum, part of our responsibility is to also make sure that they have the capacity to be able to share in the work in the ways that they want to. I think we cannot just dismiss them, as the top 10 list said, that they won't be interested in wanting to know about the research enterprise. And so I believe that, that when we engagement means that it's not just you, that we're all sitting at the table and we're recognizing the strengths and contributions of each. I also think that you need to find ways to co-publish, to to also disseminate materials that may go beyond just the peer-reviewed literature. I think that you know, we have to understand and recognize that we are working with communities and that they know more about what their needs are than we do, and that we need to just channel that in the right way. So I hope again that, you know, that this is helpful. And of course, you know, you have access to me and we can talk further offline and in other segments until we're back together in the same building. Thank you.
So our next question is from Larry. Do you have ideas about CBPR as a way of drawing people from diverse communities into our school and our field?
That's a great question, and it's a conversation that we are having, and it's a conversation that Dean McKenzie and along with other deans, Keisha Pollock-Porter, and others are having right now, so that we can think about how do we make sure that we have a diverse faculty, a diverse student body, a diverse staff, and how do we also make sure that our community partners feel that our school and this space is a welcoming space. And I really believe that these efforts that have been spurred by this moment in our history, that I hope won't be just another business as usual and you know, the window opens for a minute and shuts. But I really do believe that there are a number of committed people here at the school, you know, not just me, and certainly not just the dean's office. I think that there are many of us who really want to see a difference and to make sure that our school reflects the very best of society, and to work on removing discrimination, to make sure that people feel that this is a safe space to work in and where they are also valued, where there's no micro or macro aggressions, and where we make sure that our students understand that we are promoting an anti-racist agenda and promoting social justice.
Great, thank you, Janice. And just to repeat, because I think I was on mute for that question was, do you have ideas about CBPR as a way of drawing people from diverse communities into our school and our field? Thank you, Larry. So our next question has to do with COVID-19's impact. So we know that systemic issues frame the true incorporation of communities as co-researchers, particularly in academia. How do we address administrative challenges of hiring and retaining community partners on research teams as a function of COVID-related hiring freezes? What is the equitable workaround?
Well, I'm going to take a shot at answering that question if I were the one making that decision. So what I would say in this in response is that again, I always think about who is impacted. And we know every day from our own university, the data that we see reported on cases. We know that our colleagues at the Centers for Disease Control and the World Health Organization here in our own school and in our health departments are doing the very best to make sure we know who is impacted by COVID-19. I do believe that because of these impacted communities, we need to frame the research and we need to engage these impacted individuals in the research to help make sure that the information that is being imparted is accurate, that there is leadership for making sure that people know where to gain resources, how to access testing, how to access other essential services that may be important. And so I think that if you are creating a research project, and you're considering this, then I would certainly suggest that you talk to people who have been involved in community engaged research and practice to think about how to include some of these intended beneficiaries in this work. I think it is a missed opportunity if we do not do that. And if you have funding, then it is also an opportunity to help some of these people who may have lost their jobs due to COVID, that there are opportunity, this may be an opportunity for you to be able to hire some of the individuals from communities that whose communities have been impacted, as a way to not only elevate the validity of the work, but also to give them opportunities to build capacity. You know, we're now using and employing contact tracers in this regard, but I think that there are other ways to really bring people on board as well.
Great, thank you so much, Janice. We are out of time. I wonder if we can do one more question, if that is okay with you, Janice. There are so many great questions here. If you...
I will take one more question, okay, because I have to follow Dean McKenzie's lead on this.
Oh, okay. Dean McKenzie.
Plus, I have a party to go to.
Okay.
No more a socially distancing party.
So our final question is, please speak to the issue of promotion and tenure and how schools of public health can evaluate and value CBPR.
Great, thank you. As one of, I believe, one of the early faculty to be promoted using these methods and approaches almost exclusively, I really believe, as I said, in the benefits that schools of public health are leading the way and understanding the value of these approaches in enhancing the validity of the research and the research findings. I think that we have for a number of years tried many other more traditional forms, and I think in traditional forms are absolutely necessary, and there's room for all and for everyone, and I value the research, however you do it, if it's rigorous and thoughtful and purposeful. But I do believe that we are now opening that space, and certainly I believe Dean McKenzie and many members of the appointments and promotion committees recognize the same value and the added value that comes from doing this work. It has also helped because federal agencies, private foundations have created funding opportunities in this space as well, along with peer-reviewed publications. Are looking for this kind of writing, and so I think that this is a wonderful opportunity. We certainly have seen this across many schools of public health that have been, and many have been leading the way over the years. UNC, University of Michigan, and many others. Thank you.
Great. Thank you so much, Janice. Oh, Dean McKenzie.
Are you finished? I didn't mean to interrupt. Are you okay? Let me just wrap up. Unfortunately, we're out of time. There are many, many more questions, but we'll save the questions, and maybe Janice can reach out to some of her colleagues who have raised some questions. But I just want to take this opportunity to thank Janice for an incredibly fantastic talk. I will save the chat for you because you haven't had a chance to read all the wonderful comments that are coming in and the congratulatory messages. But you know, the chat is filled with words like inspiring, beautiful, amazing, thought-provoking, wonderful, uplifting, fabulous, eloquent, and it goes on and on and on. And I think it just begins to express the admiration that we all have for you and the work you do. And you are definitely a shining example of the kind of person you have so eloquently laid out for us that we need more of, and will continue to serve as a role model for many, many of our young public health soon to be or budding leaders in the field. So thank you so very much. I would typically invite everybody to the Wall of Wonder for a congratulatory congratulatory toast. Unfortunately, we can't do that, but please, in your own way, give a shout out to Professor Janice Bowie. She's an amazing person, and we thank you for all you do. And with that, thank you all for coming, and we'll see you soon. Have a good day.